All right, welcome everybody. Thanks for being here for CADIO's webinar series. We're so excited to kick off our spring semester with Danielle Ostendorf. Danielle Ostendorf is an assistant professor in the Division of Endocrinology, Diabetes, and Metabolism at the University of Colorado School of Medicine, Anschutz Medical Campus. Her work integrates epidemiology, exercise physiology, psychology, and dissemination and implementation science to design, optimize, and evaluate lifestyle intervention programs for adults. She engages potential adopters using human-centered design testing methods to design programs that fit patients' needs. She has been funded by the NIH and the American Heart Association for the past 10 years and currently has an NIH Career Development Award to apply the Multiphase Optimization Strategy to engage potential adopters from multiple levels to co-design a physical activity support program for adults with overweight or obesity. So again, Dr. Ostendorf, thank you so much for being here.
Yeah, thank you very much for having me. I'm honored to have the opportunity to share some of my design dilemmas that I've been going through with my factorial trial for my K. So let me get started so I can get my slides moving here. Here we go. So today I plan to overview some challenges in the prevention and treatment of chronic diseases. I'll provide a short overview of my NIH Career Development Award, the specific aims, the overall goals of the project. I'll share the original design of my pilot 2 to the 3rd factorial trial, and then go over some proposed changes that I've been considering to that design now that I actually have the funding. So I'm an epidemiologist, and I like to start out my slides with the epidemiology of chronic diseases. And the majority of my work focuses on obesity treatment through improving physical activity and nutrition, because these are considered major risk factors of chronic diseases. And things like heart disease, cancer, diabetes are the leading causes of death and disability in the United States. And they're also the leading drivers of the nation's $4.1 trillion in annual healthcare costs. But we have lots of challenges when it comes to obesity treatment. We know that weight loss is hard, and weight loss maintenance is even harder. And for example, there was a meta-analysis of weight loss studies conducted in the United States, and they showed that about 80% of lost weight was regained within 4 to 5 years. And similar patterns emerge when we're looking at adherence to diet by all different types of diet strategies, as well as physical activity guidelines. About 90% of adults do not meet the physical activity guidelines for weight management long-term, so at least 12 months or more. And then we also have significant racial and ethnic disparities and risk factors for chronic diseases. For example, compared to non-Hispanic whites, prevalence of being sufficiently active is much lower in non-Hispanic Blacks, non-Hispanic Asians, and Hispanics. And so this leads me to address 2 essential research questions in my work. The first is, what factors predict sustained adherence to healthy behavior changes? And the second is, how do we design interventions in a way that first targets sustained behavior change, and second, are equitable, translatable, and sustainable in real-world settings? And so for my K01, I just put the exact language that I included in the grant, so participants can see how a career development award might look like when using MOST. And so for my first aim, I propose to engage stakeholders to refine components of a physical activity support program called MOVE Plus. That name may be changing, but that's what we're calling it for right now. And it's for adults with overweight or obesity. And so I formed a multi-level stakeholder advisory group consisting of adult participants who have overweight or obesity, as well as organizational staff and leaders, and they're providing input throughout the 5-year project. We also conducted human-centered design testing over iterative phases in the first year of the grant. So that included this initial review of our component design and content, as well as a 12-week single-arm field trial to pilot test the delivery of the MOVE Plus program. And that was actually completed this past summer. And then in aim 2, this is what we're gearing to start in March, actually. And so I said we would conduct a pilot feasibility trial of the MOVE Plus intervention. And that would involve a cluster randomized to the third full factorial pilot trial, where we would recruit 80 adults with a BMI of 25 to 45. And all participants will receive that a 6-month widely used lifestyle weight management program delivered remotely. And that we would have 8 clusters of 10 participants that would be randomly assigned to a combination of 3 MOVE components. And the primary goal for this aim is focused on the feasibility and acceptability of the MOVE intervention, as well as the corresponding research protocol from both the participant and the delivery staff perspectives. And then I said we'd also explore effectiveness of the MOVE components on changes in theory-based constructs, physical activity, weight, and cardiometabolic health markers at 6 and 12 months. And so when I was first writing the grant, I had lots of questions in my head, like, should I go for that fully powered factorial trial, or should I hold back and propose a pilot factorial trial? And in my mind, I really, really wanted to do that fully powered factorial trial because that was the most exciting thing to me. I was like, I want to be able to have effectiveness results from this work. And then in my mind, it was like, okay, that'll reduce that step in the research timeline. So then my next R01 could be that evaluation phase of MOSE instead of having it have to be the optimization phase. And instead of, a lot of people say in dissemination and implementation science that we have a 17-year gap of how work gets translated into real world settings. And in my mind, okay, these grants can take a long time to run, to get even. And so I'm increasing that 17-year gap by potentially not proposing that fully powered design. But then I met with several different people and my mentors for the grant, and they really encouraged me to consider that pilot factorial trial instead. And they had lots of good reasons. So one was, as an early career investigator, I have never conducted a factorial trial, and it's better to start with a pilot. The second is the budget. For a K01 from NHLBI, it's $30,000 per year in project support. So that may not be able to accommodate a fully powered trial. And the third is that this pilot can provide preliminary data that will inform that fully powered factorial trial as the next step. There's lots of things you still don't know, Danielle, and that how are you going to recruit the people that you need? Are you going to be able to get everyone that you need? How is the live delivery of these components going to go? You're developing these components from scratch, and you don't really understand the acceptability and feasibilities of these components yet. And so ultimately, I decided to go with the pilot factorial design, even though in my heart, I really wanted it to be a fully powered study. And I have no regrets about that decision. So here's the study team that I put together. It includes Victoria, who's my primary mentor at University of Colorado. She's a rock star when it comes to clinical trials. Bethany Kwan is my dissemination and implementation science expert. David Conroy at Penn State is my expert on motivation for exercise. And Juliana Barnard is my mixed methods qualitative expert. Angela Famato, you guys all know. She's my MOST person. And Laura Pyle is my statistician. She has experience doing power analyses and statistical analyses for factorial trials. So it was really great to have her bio sketch included in the project. And then since the grant started, I hired a research assistant. Her name's Chloe, and she's been fantastic to work with. And so here's an overview of the study design. So in AIM-1 phase 1, we focused on just designing the MOVE program. And so we engaged 3 partner groups, 11 patients, 5 providers, and 5 leaders. And we conducted human-centered design testing. So each person had up to 2 interviews. And we shared the components with them, the prototypes, and said, hey, what do you think of them? How could we make these better? What changes do you have to recommend? And then phase 2 involved that 12-week single-arm field trial. And the goal was just to test only the MOVE components and live delivery and to see how it goes. What things could we improve on before we start that factorial trial in AIM-2, which I called phase 3 for my patient partners. And in that one, we are trying to recruit 80 patients and do a 12-month pilot feasibility trial where we're combining MOVE with an existing lifestyle intervention program called Prevent T2. That's formerly known as the Diabetes Prevention Program. And I chose that one because it's widely available, and I would like to test if MOVE can fit in something that is already existing. and how that might look in real life. We also recruited an advisory group. And so far we've had one advisory group meeting, and we'll have 2 more over the next 3 years of the grant. And within most, all of this work is couched within the preparation phase, where we are identifying that set of candidate components and pilot testing those candidate components. And then we may revise the conceptual model based on the data that we get from the factorial trial. And here's the conceptual model that I included in the grant. So this is based on self-determination theory. And the components were really informed from work that I did as part of my postdoc. And that was my F32 award funded by the NIH. And I conducted focus groups, and I asked people, what are the main barriers that you have when it comes to increasing physical activity? What messages have you gotten that make it easier? And so we have a constant component where everyone's getting these group-based classes, and then we're testing 3 other components. That includes one-on-one support sessions, membership to live stream fitness classes, and access to guided positive exercise mental imagery sessions. And the goal is that all of these will help support the satisfaction of autonomy, competence, and relatedness, and that will lead to improvements in physical activity adherence and then long-term weight loss. And our goal is to deliver all of these components virtually. So when I did the human-centered design testing in the first year of the grant, we had 4 cycles total. And the first cycle involved 10 co-designers, and we did 120-minute think aloud sessions. And we got great data and feedback from our co-designers, and they had lots of suggested changes in our language and our imagery and the actual content itself. And we made improvements after each cycle prior to the next one. And we came back to that same set of co-designers and said, okay, here's how we integrated your feedback. Now, what do you think? What additional changes can we make? And I would highly recommend doing this process with any intervention design. I personally learned so much from this, and I think the intervention materials are 1,000 times better than they were before. And I thought they were good to begin with. And so it was really exciting to see how when we integrate the people that will end up using the program, their feedback from the beginning, what changes are made. So here's the scheduled delivery for the 12-week field trial. So we heard from our co-designers that they would prefer an in-person orientation to the study. And so that's what we offered. And that was a chance for everybody to meet each other, to meet their coach, to meet the research team, hear about the goals of the study, and why we are conducting the research. And then we delivered 3 MOVE group-based classes, followed by 3 individualized support sessions. And then people had guided imagery sessions the whole time, and as well access to this online fitness center membership. I do have results for this, but I can't share it yet because it was accepted as a poster for Society of Behavioral Medicine meeting coming up in March. So if you are interested at all, come to my poster at SBM. All right, so getting to aim 2, this is where the meat of the presentation is here. So my original design was a 2 to the 3rd cluster-randomized factorial pilot trial. And so this was a figure that I put in the grant, and I said, in our constant component, everyone is getting the Prevent T2 and the MOVE group-based classes. And that constant component is delivered at the level of the group. And then we had 3 other components that we would randomize people to receive, all delivered at the level of the individual. And that included the one-on-one support sessions, the live stream fitness membership, and the mental imagery sessions. And so in the grant, I said, okay, we'll have a sample of 40 versus 40 to compare acceptability and feasibility of each component. And so, for example, for the one-on-one component, we would lump everyone together who got the one-on-one support and compare everyone who didn't get the one-on-one support. And so I chose a cluster randomized trial design in the grant because I was really worried about the risk for contamination. And for those of you who don't know what a cluster randomized trial is, the unit of randomization is at the cluster or at the level of the group. And this is really typical when you're working with schools or hospital systems. So when you have students that are nested within classrooms rather than nested within schools. And in these designs, you have to account for an inter-class correlation, which means that the people who are grouped together are going to look more similar than other people who are not in that group. So for example, with the school setting, you have students nested within a classroom are going to look more similar to each other than students nested within a separate classroom. And you have to account for that inter-class correlation when you're doing a power analysis, and also on the back end when you're analyzing the data from the trial. And I mentioned contamination. And so this can occur when aspects of an intervention are adopted by members of the group that was randomized to not receive that intervention. And when this occurs in a clinical trial, it can dilute the observed differences between comparators, and it can affect the reliability and the validity of a study. And so since I had a component delivered at the group level, I was like, okay, doing it at a cluster randomized trial will prevent contamination, will keep everyone within their experimental condition together. They won't have any interaction with other people in other experimental conditions, and that'll be super clean. And for the power, this was exact language that I put in the grant for the KO1. And so I said, our sample of 40 participants per move component is appropriate to assess our primary outcomes of feasibility and acceptability based on other pilot study reviews. And then I reminded the reviewers, while our focus in this most preparation phase is on feasibility, not effectiveness, we still conducted a power analysis, and here's the effect size that we are powered to detect. So I still gave the reviewers the power, even though that wasn't the focus of the grant. And so based on a standard deviation of change in MVPA, or moderate to vigorous physical activity, and an interclass correlation of 0.03, which was estimated from a prior lifestyle intervention trial, we showed that with a 15% attrition and 32 people per move component, that would provide 80% power at 5% significance to detect an effect size of 0.86, or a change of 25 minutes per day in MVPA at month 6. So I reminded the reviewers again and said, this is a moderate effect, but remember here, the primary purpose of AIM-2 is for me to receive training in conducting a factorial trial and to collect feasibility data to inform the delivery of Move Plus in a fully powered R01 factorial trial. So we chose that smaller sample size to maintain appropriate scope. So in my mind, this is how I was going to do it in real life. And so I knew that we could accommodate about 20 participants receiving the intervention at one time. And so I was thinking, okay, we'll be able to run 2 experimental conditions at one time. So we'll try to recruit 20 people in a first cohort. And maybe we can have the coach who's delivering these group-based classes do it on the same night. And so, for example, experimental condition 1 would get the group-based classes on Wednesday nights from 4:30 to 5:30. And then the next class would happen in experimental condition 5, who would get the group-based class on Wednesdays from 5:45 to 6:45. So here the registered dietitian and the coach is having to teach the same material back to back to 2 different groups. And that can be costly for the registered dietitian's time, because she's having to teach the same material twice. But it also makes sure that the experimental conditions, the people within those never see each other. They never have any interaction with the other conditions. And then I was thinking, okay, the registered dietitian probably doesn't have a capacity to deliver 20 one-on-one support sessions within the span of 2 weeks. That's scheduling with 20 different people, 20 different schedules, and these sessions last 45 minutes. And so maybe I should stratify the randomization by the presence of one-on-one support. So that way my coach is only having to do one-on-one support with 10 participants within a cohort. And so I didn't think about that when I wrote the grant, but then I was like, okay, how do we actually do this? I need to consider the time of that coach. So here was a sample study timeline for 4 cohorts. I would plan to start my first cohort this month in January 2024, and then have our last cohort end by January 2027. And the end of the 5-year grant is actually April 2027. And so that really only gave me like 3 or 4 months to complete the final outcome measure. and then also have all of data be collected for the trial. Hopefully there'd be that 1 year no cost extension, but it is a pretty tight timeline with that, doing 4 cohorts here. So here's the scheduled delivery of how we would integrate the MOVE program with Prevent T2. So again, we're going to be offering that in-person introduction to the study. And then we'll have Prevent T2 group-based classes, and those will be mixed in with the MOVE group-based classes over the 26 weeks. And then the other components, it'll depend on which condition participants are randomized to either receive that one-on-one support for MOVE, guided imagery sessions, or access to online fitness center membership. So here's the primary outcomes. I mentioned we're focused on acceptability and feasibility here. And so with that cluster randomized trial design, we could do focus groups and have participants at the end of each 6-month program, bring them back in and say, how was your experience in the study? What things went well? Okay, you were the group that got all 3 components. What was that like? Was it too much? Was there things we could have done differently? We also are collecting measures. It's AIM, FIM, and IM. It's Brian Weiner's measures for acceptability and feasibility. They're very short. I think they're 4 items. So a really great measure to add if you're looking at acceptability, feasibility measures. And then we're looking at study protocol stuff. So reach and recruitment, treatment adherence, how many participants are completing our outcome measures? Are we retaining everybody? If we're having dropout, is it differential by experimental condition? Here is the proposed clinical measures. So we're going to capture changes in physical activity using the ActivePal device, changes in weight and body composition using DEXA, energy intake using a 3-day food record, blood pressure, fitness, cardiometabolic biomarkers. And I also added gut microbiome. I have a colleague who is willing to pay for the stool kits to get added to the study. So we added that piece, which will be really interesting outcome measure to explore. And then we also have several psychosocial outcomes, including motivation for exercise, psychological needs, imagery ability, imagery vividness, weight bias, self-efficacy. So a whole host of questionnaires here that we're going to collect. Okay, so you got the grant. Now, how will you actually do it? It's like that moment of like, okay, wow, now I need to actually do this. What is that going to look like? And there's so many practical considerations that come into play. The first are increased costs. Everything went up. From when I submitted my budget to when the grant actually got funded, we had so many changes at the university. And one of the biggest ones was in salaries. And so we had this thing called compression increases where they realized that a lot of staff at University of Colorado weren't being paid what they should be, which is a problem. And so, for example, what I originally budgeted for a research assistant for 20% of their time was for a $40,000 salary, and that no longer exists at University of Colorado. I think the minimum is now around $45,000 or $47,000, and so that makes a huge change when I could only afford 20% of that person's time to begin with. And then we have increase in costs for DEXA scans, for our clinical labs, for supplies. Everything went up, and I'm looking at the budget. I'm like, okay, how am I actually going to do this? And then for intervention delivery, originally we budgeted for a registered dietitian, a $60,000 salary that person's no longer here. Now I'm budgeting for a $80,000 salary for a registered dietitian to deliver the intervention. And how much time do they actually have to deliver these one-on-one support sessions? And so that's when I kind of realized, okay, we need to make sure that they're not doing 20 people within one cohort. We need to spread that out. And then lastly, the study timeline. The ultimate goal here with AK is to get that first R01 funded. And so what are things that I can consider that might get me my preliminary data earlier, so that way I can be ready to submit that R01 a little bit earlier? Because here at University of Colorado, once that K ends, we're expected to fund 100% of our time on grants. And so that's a huge cliff that we all have to jump off of. It's a little bit terrifying. And so like, okay, what are things that I could do within this design to make sure that I'm getting the data I need maybe a little bit earlier. And so after talking with Angela Famater and my other mentorship members, I'm now considering doing this as an individually randomized group treatment trial, or IRGT. And so I'm also considering reducing the sample size from 80 down to 64. And so instead of 10 people per condition, we would have 8. And instead of randomizing at the level of the group, we would randomize at the level of the individual. And so for those of you who don't know what IRGT, it's also called a partially clustered or partially nested design. And this is typical when individuals receive at least some of their treatment in groups through a common interventionist or facilitator. So this example works really well with what I'm trying to do. Everyone is having the same coach, and then other components are being delivered individually. And again, the unit of randomization is the individual. Here, though, we have a high potential for contamination, and I'll get into that later. We also still have to consider that interclass correlation. The expectation is that this will develop over time, and maybe at baseline at 0, because these participants don't know each other, they haven't met each other. We're creating the groups like artificially as we recruit and screen people, but it'll likely develop over time, and we need to account for that in the power calculation and in the statistical analysis plan. And so here's an example timeline of the study conduct. So again, we can accommodate about 20 participants receiving the intervention at one time. And so with an IRGT, we would actually have a mix of participants within each experimental condition for each cohort. So for cohort 1, we could try to recruit 20 to 22 people, and that would mean like 2 to 3 people within each experimental condition in that first group. And so that definitely presents some issues for contamination here, but it also has some benefit, and I'll get into that. So the sample, by reducing the sample down to 64, that means we could actually complete the study within 3 cohorts and not have to do 4. And that provides some huge benefit in terms of the timeline, because then we could ideally complete the study by May of 2026, giving almost a full year before the grant ends to have all of the data collected and start the analysis and the writing of the R01. We also, with this design, still have the ability to conduct a 4th cohort if needed, and we could still fit that in the timeline. And so I like this idea because it gives me some flexibility. Like, okay, maybe we start with trying to get 64 and we get to that and we say, okay, we still don't have great data on acceptability, feasibility. Let's still run a 4th cohort. And we could still do that within the timeline of the grant and try to get that original sample of 80 that we proposed. So when comparing the two, this is a table I actually put together for a meeting with my mentorship committee of all the different things that I wanted to consider. And so first was seasonality effects. When we're doing a cluster randomized trial, we're running 2 experimental clusters at the same time. And so only certain clusters will receive the bulk of the intervention in the winter, which could be problematic when we're asking people to make changes in diet and physical activity. Whereas with the IRGT, all experimental clusters are run at the same time, and that design controls for seasonality. So then we have everyone in every experimental condition being exposed to the intervention at different seasons, which I really like. That contamination. With the cluster randomized trial, there's low risk for contamination. With the IRGT, there's much higher risk, but we can include efforts to mitigate. And then the design of that larger R01. When I was thinking through, okay, the next goal is that fully powered factorial trial. I think it would be very difficult to run the fully powered factorial trial as a cluster randomized trial. It would be extremely expensive because you're having to pay for that coach or that coach's time to deliver the intervention 8 different times, if it's a 2 to the 3rd design. Whereas the IRGT would be easier and cheaper to run. And there's a huge difference in the budget when it comes to delivering the program. So with that cluster randomized trial design, it would cost us around $60,000 to deliver the program. Whereas with the IRGT, it would cost almost half. And so that's a huge difference in the budget. And then for staff time with the cluster randomized trial, it's more registered dietitian time compared to the IRGT. And then how does this impact delivery of the MOVE program? So with that cluster randomized trial, yeah, I would have had the ability to like really specialize how each group was receiving the program. And so, for example, in that condition 8, where all of the conditions are turned on, they're getting all 3 components. I could say in the group-based classes, have the coach remind them, remember, one-on-one support sessions are coming up. Make sure to schedule that with me. I'm going to be sending out an email to schedule. And don't forget your guided imagery sessions. The link can be accessed here. And remember that fitness app that you have access to. There's a great class I recommend trying. And that could be a really integrated way of delivering the program. Whereas with the IRGT, we can't do that because everyone's mixed together in that group-based class. So all communication about those other components would have to be done through email or individually with each participant, just to make sure we prevent any risk of contamination there. So for sample size, comparing the 80 versus the 64. So with 80, we would have 10 per experimental condition. With 64, we'd have 8. The total budget, it makes a big difference for the total budget, because then when you reduce the sample, that reduces the number of outcome measures you have to do, the number of pregnancy tests you need to buy, the number of DEXA scans you need to pay for, clinical labs that need to be drawn. And so it put our budget much closer within what we actually have funding to do, which is around $150,000. And then the staff time is also reduced. It's less people we have to recruit and screen, less people we have to bring back in for outcome measures. And so I was reminded by this statement in Leon et al., who has a great publication on the goal of pilot studies. And they say a pilot sample size is based on the pragmatics of recruitment and the necessities for examining feasibility. Pilot study proposed sample size is based on pragmatics such as patient flow and constraints. And so my mentorship committee, we're all on board with reducing the sample size down to 64, but then still leaving room to do the trial with 80 if we needed to. And this is how it impacted power. And so my statistician, Laura Pyle, she ran power analyses for 3 different scenarios: a sample of 80, a sample of 72, and a sample of 64. And we couldn't use the same attrition estimates, because if we had 15% attrition for 64, that would leave an imbalance across experimental conditions. And so she proposed a attrition of 11%, where we would have a final sample size of 7 per condition. The coherence V was still quite large in all 3, and our detectable effect size was around 25 to 26 minutes a day. And I, again, was reminded, okay, the goal of this trial is not to assess effectiveness, it's to assess feasibility and acceptability of these components. And so I think it would still be okay to propose that smaller sample size. Another question that I was considering is, should I stratify randomization by gender? And reasons for yes is that we typically recruit 80% women in these types of trials, and so it lessens the chance that men end up all in the same group, and that men and women may experience the program and the MOVE components differently, and maybe we need to control for that in the randomization scheme. But reasons for no is that there's the potential for imbalance across experimental conditions. And so I had my statistician run 5,000 simulated trials. And in a worst case scenario, there would be an imbalance of 8 if we're targeting a sample of 64. So we could have 4 experimental conditions that have a sample of 9 and 4 that have a sample of 7. And that could be really problematic if we're trying to assess if there's differential dropout by experimental condition. And so ultimately, I don't think I'm going to stratify by gender because of this risk. But I could be swayed. I haven't made a final decision yet. Okay, There's also impacts on qualitative data collection. And so in that cluster randomized trial design, we could easily do focus groups because all the participants were kept together. There was no cross-contamination with experimental conditions. And so transcription costs to do 8 90-minute focus groups were around $1,800. Not too much for analysis time because it's 8 transcripts to review and code for. And then subject compensation was around $3,000. For the IRGT, we can no longer do focus groups. We can't say, okay, let's get 10 people and they're going to have a mix of experimental conditions, because we can't say, okay, how was it receiving one-on-one support sessions? And when half of the people in that group didn't even get those. And so now we would have to switch that collection method to be interviews. And so I was thinking, okay, we could probably propose to do 40 60-minute interviews and have at least 20 versus 20 for each component. Transcription costs are higher. Analysis time is much higher because now we have 40 transcripts to code and analyze. But that could allow us to finish up the data collection a little bit earlier. We could do all the interviews by the end of the second cohort, giving us some great qualitative data for that RO1. Another option that I considered was to do small groups. So we could have 16 interviews of 2 to 3 people. And those 2 to 3 people would be people who were in that same experimental condition. And the costs were pretty similar, I would say, in terms of transcription. Okay. So for the in-person orientation, this also changes the plans. If we're going to do that IRGT, we can't necessarily have everyone come together at the beginning and then share with them, okay, this is what one-on-one support is going to be like. This is what the fitness classes are going to be like, because not everyone's getting those. And so what we could do in the orientation is say, okay, here's the components that everyone's going to get: the Prevent T2 program and the Move group-based classes. Here's what you can expect for our schedule of outcome measures. And the goal is really to gain participant buy-in from the beginning and say, hey, we have no idea the effect of these components that we're testing. Some of them could be helpful, but they could also be more burdensome. And so we need to make sure that you guys are bought into this trial design, and that way you can help us limit risk of contamination. And then for orienting people to those individualized components, we decided that we could do recorded videos. So we could have a video of what one-on-one support will be like, what the fitness membership app entails, how to log on, what your username is, and then how to access the guided imagery sessions and what to expect for those. And then we could just send those to participants via email to make sure that they're still getting that information that they need, even though we can't really do it in a group in-person setting. So contamination. Here's some of the things I thought of along with my committee members to help prevent the risk of contamination. So one was to overview the goal of the trial at the in-person orientation, really get people bought into that idea of the design, and then have very detailed specific instructions for each component. So if someone gets randomized to receive the fitness membership, we can say, hey, when you're in that group-based class, if you want to talk about activities you did, that's totally fine. Just don't say that you did it on your fitness app. And so we could say, it's okay to say I did yoga. It's not okay to say I did yoga using my fitness app. And then for one-on-one sessions, it's okay to say I learned this about myself, but it's not okay to say during my one-on-one with my coach, I learned X about myself. So that way people in that group-based class who aren't getting one-on-one sessions are then being pissed off, like, oh, they got the extra support. That's not fair. Where's my one-on-one sessions? And then we could also train the coach to stop any discussion of other components during the group-based classes. If someone brings it up, she could just stop it immediately and then prevent any further discussion of it. Then to measure it. So we plan on recording the group-based classes, and I'll review them for any signs of contamination. So at the end of the study, we could say, we tried it as an IRGT and we had no contamination. This is great. And now we can plan the RO1 this way. Or we could say, yes, we had contamination. We're going to have to plan the RO1 as a cluster randomized trial to prevent this next time. I plan to implement an end of study questionnaire to ask about fitness membership use, guided imagery use. So that way, if we could potentially catch people if they didn't get the fitness membership, but then they started a membership somewhere else, we could understand, okay, were they doing something else that they weren't supposed to be doing? And then we could ask participants about their experience in the interview of what was it like to not be able to discuss these things? Did that impact, your experience in the program? Okay. Other strategies to reduce costs. One idea that we had was to just not do the DEXA scan at month 12, since our month 6 is the primary outcome time point. And then for eating intake, originally I proposed to do a 3-day food record, and we would have our CCTSI Nutrition Core analyze those records. That would have cost around $8,000. And so I plan on switching this to the ASA 24, which is free and will give me the same type of data. And then for the cardiometabolic biomarkers, at month 12, we decided that we're still going to do a blood draw. We're just not going to have the blood analyzed. And so we're going to store that blood in a PI tube, and hopefully I can have other funds that I can use to pay for the analysis of those labs later. So we're still collecting the data. We just won't have the lab values right away. So questions to consider when you're planning a pilot factorial trial design. First and foremost is, what is that next grant going to look like? What data do you need to support getting that R01? And how does that design impact your primary outcomes? How can you prevent and measure contamination? And how does this design impact power? And how does it impact the cost to conduct the trial? So in summary, there's many design decisions to consider when planning a factorial trial. Remember that all costs will increase from the time you submit your grant budget to the time you actually start it, and build it into your budget if possible. Lean on your mentorship team for guidance. I've been so thankful for their support. And remember, at the end of the day, this is a training grant and your goal is to learn, and you can leverage any setbacks as a learning opportunity. And so with that, I would like to acknowledge my mentorship committee, my current lab members, all the funding I've been fortunate to receive, my colleagues and collaborators, as well as our research partners and study participants. And thank you for your attention, and I would like to open it up to questions.
Awesome. Thank you so much, Dr. Ostendorf. This was so interesting. I know we have a couple questions in the chat, but I want to open it up to Linda, you first, to talk a little bit about stratification.
Yeah, I just wanted to ask Danielle for a little clarification about what you said about stratification. So I guess I wasn't clear on why you thought that could lead to imbalance. Can you explain that?
Yeah, so with stratification, what we normally do in our lifestyle intervention trials is we take all the women and we randomize them to their groups, and then we take all the men and then randomize them to the group. And if you don't have like an even number of men and women, that could lead to imbalance across the conditions. And so I asked my statistician to run like 5,000 simulated trials of like what could be the worst case scenario. Ideally you don't have any imbalance and it works out perfectly, but sometimes it could happen where you do. And so there is a risk. 8 is very high, and she said that that's a very unlikely. The average, I think, would have been 3. But since my numbers are already so small to begin with within my experimental conditions, I'm a little bit worried about it.
So are you not using permuted blocks randomization then?
I don't know. I'll have to ask my statistician how she ran that 5,000 simulated trials, because the difference.
If you use permuted blocks randomization, so with that type of randomization, let's say you have 8 experimental conditions, then you randomize in blocks. So you would permute the random integers 1 through 8, and then that would tell you where to put the first 8 participants, and then you permute them again, and that tells you where to put the second 8 participants, and so on. And what that means is you're putting a participant in each experimental condition, and you don't go on to another you don't go on to it. You don't go on until you've hit all the conditions.
Okay, yeah,
And if you stratify using that approach, that really limits the amount of imbalance you can have. I mean,
okay,
you could end up with one more male or female, but that would be it.
okay. That's a great suggestion. I'm gonna go back to my statistician with that.
Yeah, I mean, some people don't like permuted blocks randomization because they say that once you've got the first K-1 assigned, then you know what the K is going to be. Some people feel like that's not random enough. One way to deal with that is to make the blocks larger. So you can instead of making the block the same size as the number of experimental conditions, you can make it the same size as twice the number of experimental conditions. That then opens up the possibility of a bit more imbalance, but it's still not going to be as imbalanced as it could be if you just are doing it completely randomly.
Yeah,
I just thought I'd mention that.
thank you. That's a great suggestion.
Another question for you, Danielle, from the chat. What is the sample population's average age?
Oh yeah, great question. So we're targeting an age range of 18 to 64. So it's pretty wide. And then we're also trying to over-recruit people that are underrepresented. And so we've been hanging flyers in different community centers and like laundromats, rec centers, libraries, to try to make sure people are hearing about the study in multiple different ways.
Great. And how about what is an interesting or valuable finding that you could maybe highlight from your preparation, and maybe in particular the human-centered design aspects of your preparation?
Yeah, so I learned that there's actually an interesting story. I worked with a provider who is bilingual. She teaches lifestyle intervention classes in Spanish and in English. And we had this question in our content, like exploring this idea of guilt. Like when you take time to be active, do you experience feelings of guilt? Does that come up for you? Because I had a lot of people in my focus group data earlier saying, yeah, that's a big problem for me. Like I just feel so guilty. Like I should be at home with my family cooking dinner, or I should be dropping my kids off at school, or like whatever it is that it is for them. And she told me that word guilt isn't something that she really identifies with. And she's like, I don't know if it's like the Hispanic culture or that, but like when I hear that word guilt, it means like I'm guilty of a crime or I did something really bad. And she's like, I don't like see it that way at all. And I was like, oh, that's so interesting. And so the change that I made to the curriculum was, instead of asking, when you make time for physical activity, do you have feelings of guilt? I said, when you make time for physical activity, what sorts of feelings come up for you? And then I offered ideas like guilt, shame, pride, joy. And so there could be lots of ways people think about it instead of just honing in on just guilt. And so I think it was a really great change that we made to how the question was worded to allow for multiple experiences.
Interesting. Thank you. There's also some curiosity in the chat about your approach for discussing some of these changes with the NIH and your PO.
Yeah, so I actually just had a meeting with my PO in January, like 2 weeks ago, to discuss these changes with her. And she was on board with these changes, but she was also like, I really want to make sure that you are getting the data that you need for the R01. That was her biggest emphasis to me. And she's like, I know that there's budgetary changes and costs have increased. And she's like, and she had a few questions for me. Are you reducing the sample size because you are worried that you can't actually recruit 80? Or is it something else? And I was like, no, I'm not actually worried. I think I could recruit 80. We have precedent sent for similar inclusion exclusion criteria for getting 165 over the same time frame. But what I am worried about is actually the cost of doing everything. And I told her about the compression increases for salaries, how costs of labs have gone up. And so she just was like, that is very justifiable. She's like, I just want to make sure that, you know, in your progress report, which is coming up, I'm submitting it at the end of this month, that you indicate how you're still going to meet the goals of the grant and how that's still going to lead to your next R01.
Interesting. Everyone's so welcome to put further questions in the chat. In the meantime, I also have one. You know, I thought that your slide about how you handled the grant writing process specific to piloting and what your pilot outcomes were and effectiveness was really useful to see. We frequently get a lot of questions about that. And I was curious whether you got any pushback from reviewers or found anything, you know, whether providing them that little power analysis made people think in terms of effectiveness, or whether that seemed to maybe satisfy the few that were thinking along the effectiveness lines. What was your experience like in the review process?
Yeah, so my first grant I submitted, I think it scored like a 32, and it was right on the border of being funded. And my program officer was like, you need to plan for a resubmission. And so that's what I did. While my second grant was under review, they told me that my original grant was going to be funded. And so I got actually the opportunity to have reviews on both though. And so in the first review, I did get feedback from like the most piece of it was that reviewers really loved that I was using most and having that as a framework to guide the optimization of the intervention. I did have one reviewer 3, who said, oh, you're only having 10 in each experimental condition. That's not going to be enough. And so in the revised grant, I didn't put any focus on that number of 10. I said in multiple places, since we're comparing 40 versus 40, I reminded them, like, basically hit them over the head that it's not 10 versus 10 versus 10 versus 10. It's 40 versus 40. And so I don't know how many times I said that in the grant, but it was quite a few. And I didn't get any negative feedback on it in the second round. And so I think I approached it a much better way in the revised grant.
Well, that's really useful to hear. There's another question in the chat that is sort of on the same topic we're on right now, but maybe you could add a little bit more. Did you have any reviewer comments related to conducting most that you did not anticipate? And also any advice for those considering proposing a pilot study using most?
Yeah, I don't think I had any comments that I wasn't anticipating. There weren't any surprises to me from the reviewer comments. Advice though, I would just like try to remind the reviewers that you're receiving training in this, and that this really aligns with your career development plan of learning how to conduct, if it's a factorial trial that you're proposing as part of most. I know there's other designs in the optimization phase, but really remind the reviewer what stage you're at, because they tend to forget and they tend to review it as like an R01, and which seems to be unfair when you're coming at it with very little experience running a clinical trial. So I just try to remind, I would put in parentheses in the grant, like maps on to training aim 2. So that way they could see how my research aim 2 fit with my career development plan, and that there was like extreme overlap in the two.
Great. Another question, how much did you do to learn about most before you submitted the first time?
Yeah, so I read Linda's book and I had attended a few webinars on it. And I remember hearing about like the initial results of the opt-in trial. I think it was at, I forget which conference it was presented at. And then I met with several other people who already had Ks successfully funded one-on-one, just to get advice about how to approach the grant. And I was lucky in that a lot of them were willing to share their grants with me. And so I was able to see how they pitched the idea of using most and having a factorial trial in their grant, in a very low funded grant, and how they made that work. And so I just kind of like put in pieces that I liked from other people's grant, but made it my own. But I had lots of meetings with different people, and I didn't know who my most mentor was going to be. I ended up meeting with Angela from Otter like twice during the grant writing process, and her feedback was just so good. And it was so in line with the way I was thinking about approaching the grant and how to actually merge dissemination implementation science principles into the grant. And her way of thinking about it was really in line with how I wanted to approach the grant. So that's when I asked her if she would mind being my most expert on the grant. But now that I've done it, I think there's so much more to learn. I think you can submit the grant without knowing too much, but it's once you get it, you're like, okay, now you have to actually learn this. So
that sounds appropriate for a training grant.
yeah.
Great. Well, I see we're about at time, and I think we've gotten to all the questions. Danielle, thank you again for your presentation and your time with the questions. It was extremely useful, I'm sure, for all of us.
Yeah, thank you so much for everyone for attending and for your questions, and for that person that shared the link in the chat. I really appreciate it. So hope you all have a great rest of the day.
Yes, thank you, everybody.